Today I will start with a new topic. I already finished with glaucoma. Okay, so start with strabismus. Am I audible at the back? Okay. So what is strabismus? How will you define? Anybody? अब दरवाज़ा लगा दीजिए अंकित. Sit in the front row. So what do you understand when I say strabismus or squint? Yes, anyone? When I say patient has a squint, means patient's eye is deviated. Okay, so deviation of the eye is squint. But when we define it as a misalignment of the visual axis. The eyes are not aligned to each other, right? So today I will be covering. Okay. So when the visual axis of two eyes are not aligned to each other, it is called squint or strabismus. So what is visual axis? What is visual axis? When the visual axis two eyes are not aligned to each other, we call it as strabismus. So what is visual axis? You should know what is visual axis? What is visual axis? Yes? Line joining the object of fixation to the fovea. When I am seeing a particular object, I am fixing at a particular object, then line which joins this object of fixation with my fovea is called the visual axis of that eye. Okay? So normally when eyes are aligned to each other, both eyes are looking at the same object, image is forming on the fovea. So both the visual axes are going from the object of fixation to the fovea, and both are looking at the same object, and since the image is forming on the fovea and the two eyes, they are same, forming the same point, therefore the brain is going to fuse these two images, we perceive it as a single image. Okay, that is the funda of binocular vision. Right? So when the eyes are aligned to each other, visual axes are aligned to each other, means both the visual axes are on the same object, then we call it as a patient's eyes are perfectly aligned to each other. There is no strabismus, and we call it as a orthophoria. Okay? Means eyes are perfect, which the patient is orthophoric, means patient's eyes are completely aligned to each other. Okay? For example, in this patient, the eyes are perfectly aligned. The child is looking at the object of interest with both eyes, but here you see this eye is deviated inwards. So this eye is not looking at the object. So image is not falling on the fovea in this eye. Will it fall on the fovea in this eye? Because child is not fixing at the object. When you ask the child to look at the object, child is seeing only with this eye, not with this eye, because this eye is deviated inwards. Okay? So this is not orthophoria, this is orthophoria. Okay? So visual axis is a line extending from the point of fixation to the fovea is called the visual axis. They are aligned to each other, we call it as a orthophoric patient, otherwise we call it as a patient has a squint. But how will you find out the eyes are aligned to each other? How will you find out the eyes are aligned to each other? There has to be some test to prove that yes, eyes are aligned to each other. So for this you have to do a simple test called a torch reflex test, in which you throw the light okay, so you just have to throw the light on the patient's eye, and this is the pupil. You are not supposed to come late in every class. Every class I find keep on coming and I continue my lecture. Any reason? How many of you are there? Come inside. Next time in 8 o'clock class on Tuesday, I am going to allow anyone after 9, after the time. Okay, come inside and sit on the front desk now. You are disturbing the class. Close the door now. Okay, so how will you find out the eyes are aligned to each other? There has to be some test to prove that the eyes are aligned, the visual axis is perfectly aligned and there is no squint. So for this, you can do a simple torch reflex test, in which you throw the light on patient's here forehead, ask the patient to look into the light, and when patient looking into your torch, you will find that the reflex is in the center. Okay. So if the reflex in the center in both the pupils, means the patient is fixing with the both eyes to the object of interest, and the eyes are, and the image is falling on the fovea. Like in this patient, if you see, you can see the reflex of the torch in the both eyes in the center. Okay, so simple test, just throw the torch light and close the door, close the door. दरवाज़ा बंद कर दो. Okay, so when you start examining the patient, you want to see whether the patient has squint or not. So just do a simple torchlight test, throw the light on the forehead, ask the patient look into the torch, and you will find both eyes are looking simultaneously on the torch. Patient is fixing with the fovea and two eyes, and then you find the reflex in the center of the pupil in both the eyes. Correct? So then you say that the eyes are perfectly aligned. There is no any manifest squint. Okay? You don't find any manifest squint. But what will happen in this case? Where the reflex is falling? Is it in the center? Where it is? Where is the reflex? Can you see the reflex? This one? It is on the temporal limbus. Can you see this? It is on the temporal limbus. It means what kind of deviation it is? Eye is not straight, it is deviated inwards. Okay? So, based on the location of the reflex, you can say it is a iso deviation or an exo deviation. Here in this case, it is somewhere here or somewhere here, right at the limbus. Okay? So, this eye is deviated inwards. So, we call it as a iso deviation or a convergent squint. Okay? But suppose the eye is deviated outwards, then the reflex will be somewhere here. Okay? The reflex will be the nasal limbus, means the eye is deviated outwards, so it will be exodeviation. Right? That is how you find out whether there is a orthophoric, the eyes are aligned or eyes are not aligned to each other. There is a misalignment of the visual axis two eyes, the patient has a manifest squint. Okay? In large angular deviation, you can obviously see from distance that this eye is deviated. But small angular deviation, you may have to look carefully for 5 or 10 degree of deviation. You have to see for the torch reflex that is in the center of the pupil or it is on the nasal or the temporal side. And then you can say this, it is not in the center, so patient has squint. So this is, I said, this is the object of fixation. It is falling on the fovea, here falling on the fovea. So this is going to, this is orthophoric. But again in this case you see this eye is, what is the type of deviation here? What is the type of deviation? Iso deviation. Okay, so eye is convergent. So now this eye is convergent. So image is not falling on the fovea because now fovea has shifted temporally. Okay, because this eye is fovea shifted temporally, and therefore this is not falling on the fovea. It is falling somewhere else on the extrafoveal point. And because of this reason, sit here. Because of this reason, this child is will not. It is a squinting eye. Okay. So this child eye axis are not aligned to each other. Okay. So this fovea is direction of the fovea visual axis has to be this, but since eye is deviated inwards, therefore the image is not falling, is falling on some other point, extrafoveal point. So now the brain is not going to fuse these two images because they are not coming from the same point, and these are known as retinal corresponding points. Okay. So in retina there are many corresponding retinal points. If the image falls on those 2 points in the eye, then only brain is going to fuse. If the image does not fall in the fovea, then the quality of image will not be the same as in the normal eye. Okay. You know fovea has a maximum visual acuity, sharpest visual acuity. So the image in this size falling on the fovea will have a different quality, whereas image falling on the some extrafoveal point somewhere here will not have the same quality of the image. It is a blurred image. So brain is not going to fuse those images. So patient will have a uniocular vision. Okay. These patients who have a squint, a large degree of squint, will not have a binocular vision. Brain is not going to fuse these two images. So patient will be seeing only with one eye, other patient is not seeing because image is not falling on the fovea. So you can say obviously this patient has a squint. Now those two cases I showed you were a manifest squint. Obviously you can see from distance the child eye is deviated. Okay, the one has exo, one has iso deviation. But patient may have a latent squint. Okay, so latent squint is the alignment is maintained with the effort of fusion, and there is always tendency to deviate when we break the fusion. Means if you do the torch reflex test, the eyes will be perfectly aligned to each other. Okay, but patient may have a tendency for deviation. That's called a latent squint. That was a manifest squint. You can see from distance there is a large deviation. You can remember this eye as iso or exo deviation. But there may be a latent squint called as heterophoria, where by effort of fusion the alignment is maintained, but as soon as you close one eye and break the fusion, break the binocular vision, this eye deviates. Okay, because patient has a latent squint. So we have to elicit the latent squint. We have to find out, do a test, cover uncover test to see whether the eye is still maintaining fixation or there is a tendency for deviation, which is called latent squint. And if persists for a longer duration, it may come into manifest squint. Okay. So heterophoria, latent squint is alignment is maintained with effort of fusion, but there is always tendency for eye to deviate when the fusion is broken. So in this patient, this may be having latent squint, may not be having latent squint. So what you have to do is, after doing a torch reflex test, you find there is no manifest squint. eyes are perfectly aligned, the reflex in the center of the pupil in both eyes, but then you cover one eye, okay. Cover with the hand one eye, wait for few seconds, you have broken the fusion, you have broken the binocular vision, okay. Now suppose this patient has a weak fusional reflexes, then this eye under cover will deviate. So you uncover this eye which you have covered and see what is happening to the eye. So when you uncover the eye, you will find this eye is making a movement again to take the fixation at the object of fixation. So it has a binocular vision, but it is a weak, and therefore when you cover, you break the fusion. When you break the binocular vision, there is tendency for deviation. So when you cover one eye, wait for a few seconds, uncover and see what is happening in this eye. Patient does not have latent squint, then nothing will happen, the eye will not move at all. But if patients have weak fusional reserve and you cover the eye and you remove the cover, you see this eye again was moving out under cover. As soon as you remove the cover, this eye again moves to take up the fixation, because still binocular alignment is maintained, okay. That is how you look for latent squint, by cover uncover test. You cover it, uncover it, cover it, uncover it. You will find you are breaking the fusion by covering the eye, so the eye has a tendency to deviate. So it will move out exo or ezo, right. So when you uncover the eye, you find this eye and can make a movement so as to make the fixation, because patient still has a ocular alignment when you are not breaking the fusion, okay. That is called the heterophoria or the latent squint. I hope I made it clear, okay. So this child is orthophoric otherwise, but you have to prove orthophoria, and to prove that there is no latent squint, you have to do a cover uncover test. Cover this eye or cover this eye and see what is happening by breaking the fusion in the two eyes. So you find under cover the eye deviates. How will you know eye deviates? You uncover and see what is happening. So this eye will immediately make a movement to take the fixation, okay, because when uncovering, patient is able to maintain the ocular alignment, right. That is how we diagnose latent squint or a heterophoria. And this is a manifest squint known as heterotropia, because the angular deviation is very large. You can obviously see that the patient has a manifest exodeviation. So it is called a heterotropia, which is always present. This I already told you, cover uncover test. So how will you find out? When you are not covering any of the eye, you are doing torch reflex test, the eyes appears normal, perfectly aligned to each other. But as soon as you cover one eye, there is a tendency for deviation. So eye under cover will deviate. So how will you know it is deviating? You uncover this eye, so cover uncover test, and you see that eye immediately takes a movement to fix at the torch, okay. So if you find on covering and uncovering there is a movement of the eye which is either ezo or exo, could be, more is exo. So if the eye was out under cover, as soon as you remove the cover, you will find this immediately moves. You find there is a movement to take up the fixation. That is the cover uncover test to diagnose heterophoria or latent squint. Clear? Now based on the direction, we label them as ezo, exo. Already I told you what is esophoria, what is exophoria. Horizontal deviation, inward turning is ezo, outward is exophoria. Phoria, because we are talking of latent squint. Tropias are manifest squint. Hyper means there is a upward turn, shifting of the eye, and hypo is downward shifting of the eye. So when you do cover uncover test to diagnose phorias, then you notice the movement of the eye. If it is moving upward, means the eye moves down to take fixation, means there was a hyperphoria, or if eye moves down to take up the fixation, that there was a hypophoria. So you have to, based on the direction of deviation, you can label it as different types of phorias, okay, exo, ezo, hypo or hyperphoria. Then similarly we have tropias also. Tropia means manifest squint, heterotropia means a manifest squint. Now again based on direction, it can be exo, this eye is deviated out, and it is a manifest squint, because you do not have to do any cover and cover test to diagnose it. It is obviously from distance you can say this eye is deviated outward, this is inward ezo, this is up is hypo, and this is hyper. So hypo and hyper. So this is a manifest squint, whether you do not have to do any test, you can see that the eye is squinting obviously, and based on direction you say this patient has heterotropia and it has a exotropia, esotropia, hyper or hypertropia. But if the eyes are aligned, you have to do cover and cover test to prove the patient does not have any latent squint also besides manifest, okay. So that is how you diagnose latent and a manifest squint. Now let us come to a origin, insertion and action of various extraocular muscle, because to understand the squint you should know what are the origin, insertion and action of all these muscles, okay. So you all know that there are 4 recti, 2 oblique muscles, okay. All the recti take origin from, yes, recti take origin from annulus of Zinn, present at the apex of the orbit. So they take origin from here, annulus of Zinn. All the recti, they come straight forward, get inserted at fixed distances from the limbus, okay, medial lateral rectus, superior inferior rectus, all these. Then there are 2 obliques also. What is the origin of superior oblique? From where the superior oblique takes origin? Yes, your knowledge of anatomy. Anyone? From where the superior oblique takes origin? All recta take origin from the annulus of Zinn, which is at the apex of the orbit, right? They come straight and inserted at the limbus. But what is the origin of superior and inferior oblique muscles? Anyone? Anybody? Yes? It takes origin from the sphenoid bone, just above the annulus of Zinn, from the laser wing of the sphenoid. Okay? From here it goes straight. There is a trochlea near the medial wall. From there it turns backwards and inserted behind the equator in an oblique manner. This is very important. Why it is important? Because it determines the action of the muscle. How it is inserted, from where it takes origin, what is the course of the muscle. So, action will depend on the course of the muscle. The inferior oblique takes origin from the floor of the orbit, here near the lacrimal fossa. Okay. Then goes behind the equator, okay, below the inferior rectus, and gets inserted behind the equator in an oblique manner. Okay. This is important to know because the action will be different, because so what is the action of superior rectus muscle? Please speak. Elevation. What is the action of superior oblique? Both are superior. One is superior rectus, superior oblique. What is the action of superior oblique? Is it elevation? Depression. Depression and intorsion. Okay. So, this is a superior oblique inserted superiorly, but action is depression, but superior rectus has an elevation. Why this? Because of the origin insertion of the muscle. Where it inserted, what is the direction of the muscle from the apex to the globe. Okay. So, SR is the longest muscle which turns backwards and then inserted over the globe behind the equator in an oblique manner. This is a straight insertion. Can you see? This is lateral rectus is inserted straight. This is inserted in an oblique manner, that too behind the equator. So, actions will be different, okay, based on the course of the muscle in the orbit. This already covered. Now, insertion is also important in these muscles, which will determine the action of the muscle. So, the medial rectus inserted in a straight line 5.5 meter from the limbus. Why this distance is important? This is 5.5, this is 6.5, approximately 7.7. Okay, you have to remember like this, the distance of the insertion from the limbus of this muscle. So, what is the importance of these millimeters and straight? Medial lateral rectus are inserted straight in a straight line, but you see the superior inferior rectus, they are not inserted in a straight line, they are slightly obliquely. Can you see from this picture? These are inserted in straight line, medial lateral rectus, right, 5.5, around 6.9 or 7 millimeters from the limbus. Whereas this muscle, the inferior rectus, superior rectus, are inserted in a slightly oblique manner. Now, what is the importance of knowing this distance from the limbus? Why important to know the distance from the limbus? Surgical importance, applied importance. Because when we are operating on the muscle in case of squint, where will you find the squint? The muscle, the insertion of the muscle, you should know where to look for. If you are looking at medial rectus 5.5, so insert the muscle hook at 5.5 and you will catch hold of the medial rectus muscle. So, surgical anatomy is very, very important of this, where the inserted, how it is inserted, okay, that is very important. So, if you want to isolate the medial rectus muscle for this surgery of medial rectus, then you have to look at 5.5 meter, you will find the muscle there only, the insertion of the tendon of the muscle. So, it is important to remember all these figures, where it is inserted, how it is inserted, correct. And obliques I told you already inserted behind the equator. These are anteriorly, this is behind the equator in an oblique manner. So, why it is I am stressing upon? Because action will determine, action of the muscle is determined by how it is inserted, where it is inserted. This you already know, the nerve supply SO4LR6, you already all know which muscle, which nerve supplies the muscle. This is the blood supply coming to ocular movements. Okay. So, the ocular movements occur along a plane which is known as listing plane. This is the plane along which the movement of the eyeball occurs, and it occurs around 3 axes known as axis of Fick. Okay. So, how the eyeball moves? Eyeball moves around 3 axes X, Y and Z, and it moves along the listing plane which is located at the equator of the globe. Okay. So, what are the movements of the eyeball? Can you tell me what are the movements of the eyeball? Uniocular and binocular movements. What are they known as, and what are the different directions of the eyeball movements along the various axes? Okay. So, monocular movements are known as ductions. Remember this. Monocular movement, when you close the one eye and you are seeing the examining movement of the one eye of the patient, they are called ductions. Okay? And now based on the direction, it can be adduction or abduction, means inward movement and outward movement is adduction, going nasally, and moving the eyeball outward is the abduction. Elevation, straight looking up, depression, straight looking down, also known as supraduction and infraduction. Elevation, depression, abduction and adduction. Okay. These are the four movements of the eyeball. Now, what are the axes along which these movements are taking place? Okay. So, any movement, and there are two torsional movements also, ex-cycloduction, in-cycloduction, or in-torsion and extorsion, means eyeball is moving clockwise and anti-clockwise. Okay. Towards the nasally is intorsion, outward is extorsion. These are the torsional movements, also known as in-cyclotorsion and ex-cyclotorsion, inwards and outward rotation of the eyeball along the axis. So, now you should know what are the various axes along which the movement takes place. So, eyeball, there is a horizontal axis. So, what is the movement? It will be up and down. If you see along the horizontal movement, it will be up and down, elevation, depression, or supraduction, infraduction. This is one axis. Movement along the anteroposterior axis will be torsional movements. Okay? Intorsion, extorsion along the anterior, and along the vertical axis it will be adduction and abduction. So, there are three axes: vertical axis, horizontal and anteroposterior axis. Okay? So, along three axes the movement will take place. So, along the horizontal axis it will be elevation and depression, along the vertical it will be adduction and abduction, okay. Along the anteroposterior it will be intorsion or extorsion. So, remember this movement, duction are uniocular movement, remember this, ductions are uniocular movements tested in four directions: elevation, depression, adduction, abduction. Okay. Coming to, so when you examine and come to OPD examine the patient with any nerve palsy or myopathies, then you should know what movements to test and what direction and what are the known as. Coming to binocular movements, binocular movements are, can be conjugate, can be disconjugate. What is the meaning of conjugate? Means both eyes are moving together. Okay? You are looking to the right, looking to the left, looking up, looking down. These are conjugate binocular movements, means both eyes moving in the same direction with the same amplitude. Okay? So, these are called conjugate binocular movements, and these movements are known as versions. Binocular conjugate movements means both eyes are moving together towards the right, left, up and down. They are conjugate movements, both eyes are moving together, and they are known as versions. There are disconjugate movements also, when the both are moving in or both are moving out. Okay? These are opposite direction movements. Okay? This I am moving this time, this I am moving like this. These are known as versions. These conjugate movements, eyeball moving in opposite direction. Like in convergence, we are looking at a near object, we converge. Okay, so convergence is a disconjugate movement because eyes are going right and left. Okay, they are called disconjugate movements and they are called vergence, like convergence and divergence. When we look at distant object, the eyes diverge. When we look at near object, eyes converge. Okay, so converge and divergence are disconjugate movements. They are binocular movements, but they are disconjugate movements. So many times in patient, the eye strain we always look for convergence, whether patient's convergence is weak or it is sufficient, insufficient. If convergence is weak, patient will have eye strain and headache, not able to converge when patient is reading. Okay, that's importance of testing the convergence. So, versions are binocular conjugate movements, vergence are binocular disconjugate movements, eyes are moving in opposite direction like convergence and divergence. Now, the versions, how do we test version and how many directions we test versions or binocular conjugate movements. Okay. So, we test movements in how many? 9 directions. Okay. Remember this chart. So, center is the primary position, looking straight ahead. Okay. Looking up, both eyes simultaneously going up, conjugate binocular movement known as, they are called versions. Okay. So, supraversion or elevation will be the looking up with both eyes. Okay. Supraversion. Then depression or infraversion, both eyes looking down. So, you have to test these movements, binocular movements also, looking up, looking down, depression, infraversion or elevation, supraversion. Movements towards the right is called dextro, movements towards the left are called levo movements. Just very simple to remember. So, dextro are right side movements, levo are left side movements. So, looking straight towards the right will be dextroversion, looking towards the straight with both eyes. This is dextroversion. Okay. Looking towards the left with both eyes is levoversion. Remember dextro and levo. Okay. Dextroversion, dextro elevation, looking right and up. Dextro depression, looking right and down. Very easy to remember. Levo elevation, levo depression and levoversion. These are 3 plus 3, 6, and elevation and depression and primary position. So very easy to remember the 9 directions. So we have to test this movement when patient comes to us, say with diplopia. Okay. So then we have to test why patient has diplopia or not able to move the eye in one direction. Okay. So then we have to test all the movement and find out which muscle is affected, which muscle is paralyzed. Okay. So it's important to know the ocular movements in various directions. So they are binocular movements which are called versions, binocular conjugate movement called versions, and they are tested in 9 directions, both eyes open. And when we want to test a single eye, we test ductions, that is adduction, abduction, elevation and depression. Okay. So you should know how to test uniocular movements, how to test binocular movements, how to document them, okay, and how do you find out that which muscle is affected, why that particular movement is not happening or any muscle is overacting in that particular direction. So to find out which is the muscle which is overacting or underacting. If you know the movements and know which muscle is responsible for this particular movement. Now you know all the muscles except for MR and LR, they have secondary and tertiary actions. Why so? Because I told you, what is the reason? Because they have a straight insertion. I told you medial lateral rectus straight from the annular vision, they come and insert at the 5.5 and 7 millimeter away from the limbus in a straight line. So they have only single action. Okay. Medial rectus will do adduction, lateral rectus will do abduction. Okay. But these 4 muscles, I told you, they have an oblique insertion, and obliques have a course also differently. They come and they go back, turn superior oblique especially. So they have a secondary and a tertiary action also. So the superior rectus is the elevator, but the oblique is the depressor. Okay, remember this. Inferior rectus is a depressor, but the inferior oblique is an elevator. Okay. Now these superior, the recti are adductors. Both the recti, superior and inferior recti are adductors, whereas obliques are abductors. So you have to remember this. What are the actions? Now if you look at superior, both the superiors are intorters. Superior rectus, superior oblique, they are intorters. But the inferior are extorters. Okay, this is extorsion and this is extorter. So superior intorters, inferior extorters, recti are adductors, obliques are abductors. So there is a very simple way to remember this. Just remember these 2 sentences. You can remember action of all the muscles, primary as well as secondary and tertiary. Very easy to remember. Appears difficult. How to find out the various action of the muscles? So just remember these 2 words. Okay, the recti are adductors. Okay, you can see the 2 recti are adductors. Okay, and the superior are intorters. Okay. The superior intorter. If the superior intorter, inferior has to be extorter. Okay. If the recti are adductor, the oblique will be abductors. If you remember this, you can tell the action of every muscle, the primary, secondary and the tertiary. Okay. Remember this. Okay. To know the what are the action of the various muscles. Okay. These are the actions of the various muscles. Just remember this and you will be able to find out. Now, there are certain laws for ocular movement. Okay. So, there are certain terminology we should understand when we talk about squint further. What are agonist, what are antagonist, and what are synergistic muscles. Okay, what are agonist muscles, what are antagonist muscles, and what are synergistic muscles. Very simple. Agonist is the primary muscle which moves the eye in a given direction. For example, for elevation, superior rectus. For adduction, medial rectus. Abduction, lateral rectus. Depression, inferior rectus. That is called agonist for that particular movement. You ask what is the agonist for adduction, you will say it is the which muscle? Which is agonist for adduction? Medial rectus muscle. Okay. So this is the agonist muscle for a particular action, primary muscle which move in that particular direction. This is called the agonist muscle. Antagonist muscle in the same eye, moving eye in opposite direction. So medial rectus is responsible for adduction. So antagonist of medial rectus will be lateral rectus, right? What will be antagonist of superior rectus? It will be inferior rectus. Okay, so they are called antagonists. They have opposite action in the same eye. So called antagonist muscle. So agonist, the same muscle responsible for that primary movement, and antagonist is the muscle which has the opposite action in the same eye. So lateral rectus, the medial rectus, superior oblique, inferior oblique. Okay, or superior oblique, inferior oblique, superior rectus, inferior rectus. These are the muscles which just opposite action. They are antagonists for that muscle. Synergist means muscle in the same eye, moving the eye in same direction. For example, for elevation, I told you we have superior rectus, inferior oblique. There are 2 muscles for elevation. They are synergistic. They are helping the eyeball to move up. They are called synergistic muscles. Okay, inferior rectus, superior oblique. Superior rectus, inferior oblique. These are the muscles we are synergistic. They help in movement of the eye. They are called synergistic. They can be same eye. They can be in the opposite eye also. Okay. For example, I am seeing this eye. So lateral rectus and medial rectus are acting synergistically for this particular movement. Okay. Synergists are muscle which help in the carrying out particular direction. Now, I told you all these 9 actions, okay, the versions, I told you the version, the conjugate binocular movement called versions. Now, what are the muscles which are responsible for this particular movement? For example, if I say dextroversion, right and up, so which is the muscle, pair of muscle which is helping for this movement, one in this eye, one in this eye, a pair of muscle responsible for this particular action. Or I am looking straight towards the right. What are 2 muscles? They are called yoke muscles, one in each eye. So, for example, I am looking straight towards the right, so lateral rectus of this eye and medial rectus of this eye are the yoke muscles which are responsible for this particular action. They are called yoke muscles, okay, remember this. So, the pair of muscle in each eye which are responsible for a particular eye movement, they are called yoke muscles, okay. So, for example, if I am looking straight towards the right, it is superior rectus of the right eye and inferior oblique of the right eye because both are elevators. So, looking straight to the right will be SR of this and IO of this eye. So, very easy to remember, both are elevators. Looking towards the left side, SR of this eye, which side you are looking, and inferior oblique of this eye because both are elevator. So, when you are testing ocular movements, you find eye is not going in this direction, it means it has to be superior rectus of this eye which is not acting. Or this is overaction, inferior oblique is overacting. Could be antagonist is paralyzed. So, this is overacting, there is overaction of this muscle. So, it is important to know what are the yoke muscles responsible for particular action in both eyes. Okay. So, this I already told you, the levoversion and dextroversion, lateral rectus of this eye and medial rectus of the opposite eye, lateral rectus of the eye to which the eye is moving and the medial of the opposite side. They are called yoke muscles, pair of muscle in each eye responsible for particular action. Similarly, for the dextrodepression, inferior rectus of this eye and superior oblique this eye because both are depressors. Okay. So, these are yoke muscles, one in each eye, correct, responsible for a particular eye movement. They are called yoke muscles, they act together to carry out particular movement of the eyeball, right. Now, if you understand this yoke muscle, you are able to understand these laws also. Okay. So, they are laws of ocular movement known as Haring's law and Sharrington's law. Okay. So, there are 2 laws. What these laws say? Haring law says that conjugate eye movement, in conjugate eye movement, simultaneous and equal innervation flows to the yoke muscles. Very simple. If I want to look towards the right side, there has to be equal innervation from the brain to the lateral rectus and medial rectus, equal and simultaneous. Then only this movement is possible. Okay. If I am looking to this side, equal and simultaneous innervation has to flow to lateral rectus of this side, medial rectus. Only then this action is possible to full extent. Okay. If innervation is poor, this one eye will not move, or if there is more innervation, this eye will move more, right. So, this law says that equal and simultaneous innervation flows to the yoke muscle when we move to a particular direction in a normal conditions. Okay. This is the Haring's law which says that in conjugate eye movements, simultaneous equal innervation flows to the yoke muscles. Then only this movement is possible, otherwise one eye will overshoot, other eye will be restricted. Okay. If there is suppose paralysis of one eye, suppose there is a LR palsy, what will happen? Innervation will not flow to this eye because it is a paralyzed eye. So, eye will not move, but excess innervation will flow to the medial rectus because they are yoke muscles. So, brain knows that I have to give equal innervation to both the muscles and simultaneous. So, what will happen? This eye will overshoot medial rectus because innervation is flowing along to Haring's law to both equally. Okay. So, in LR palsy, this eye will not move to this side because there is no nerve supply or there is a paresis, will move less, but equal innervation will flow to both the yoke muscles, medial rectus will overshoot and there will be convergence excessive with this eye. Okay. More movement of this eye because of the Haring's law. So, when you test ocular movements, you find one eye is moving more, means it is because of the Haring's law, there is overaction of the opposite muscle, yoke muscle. That is the importance of knowing the agonist and antagonist and the simultaneous innervation to the both the muscles. Now, what is the Sharrington law says? This law says that it is a law of reciprocal innervation. Reciprocal means inhibitory impulses should go. So, increase innervation to the agonist. I told you what is agonist is. So, increased innervation to agonist is accompanied by reciprocal innervation to the antagonist. Reciprocal innervation means inhibition to the antagonist. Okay. So, when the agonist contract, antagonist has to relax. Okay. So, when I am moving to this side, medial rectus has to relax. Okay. Otherwise, this I will not move towards the abduction. So, when the lateral rectus is moving, I want to to this side, medial rectus is antagonist of the agonist muscle, then it has to relax. So, inhibitory impulses will flow to the antagonist muscle, then only this movement is possible. If I am looking to up, superior rectus is acting, but inferior rectus has to receive a inhibitory impulses, so that this muscle does not contract, it relaxes. So, this movement is possible. Okay. So, antagonist receive inhibitory impulses okay, simultaneously is called law of reciprocal innervation, means increased innervation to agonist accompanied by reciprocal innervation, means inhibitory impulses to the antagonist. So, when the agonist contracts, antagonist has to relax, then only this movement is possible. If both eye contract simultaneously, what will happen? Suppose the medial rectus both contract simultaneously, the medial rectus is not relaxed according to this law. What will happen? There will be globe retraction. Okay, this happens in one of the condition called Duane's retraction syndrome, okay, in which simultaneous innervation flows to both the muscles together because of abnormal innervation. So, the globe contracts. When you ask the patient to look towards the abduction, the globe contracts and there occurs ptosis, fissures becomes narrow. That is what is seen in this law is not followed. Okay. So, when agonist contract, antagonist has to relax. Inhibitory impulses should go to the antagonist muscle, then only that movement is possible. Okay. So, I told you Duane's retraction syndrome, simultaneous innervation flows to both medial and lateral rectus. So, when you, on attempted lateral abduction, the eye globe get retracted because both the muscles contracting simultaneously, it is not getting inhibitory impulses. So, both the muscles contracting simultaneously. So, what is happening is eyeball get retracted, the eyelid droops down, the patient has a narrowing of fissure when looking to the lateral side. This is how we diagnose this syndrome. Okay, it is a congenital condition. That is the importance of these laws. Or if any muscle is overacting because of Harring's law. Okay, so if impulses are flowing to the synergistic muscle, then patient may have a overaction of that muscle because of the Harring's law. So, you should understand what are the muscles origin, what is the action of the muscles, what are the various uniocular movements, what are the various binocular movements, in how many directions you are going to test the binocular movements, the versions, the vergence, the conjugate eye movements, the disconjugate eye movements, okay, and what are the agonist, antagonist and synergistic, and what are the laws, Harring's law and Harring's law of simultaneous innervation to yoke muscles to carry out a particular binocular movement, and Sheraton's law of reciprocal inhibition so as to relax the antagonist when agonist is contracting for the movement to occur. Okay, this was about the muscles, ocular movements, now supply. Okay. Now, we move on to the binocular single vision. Any doubts till now? Okay. So, we come to binocular vision. So, simple, what is binocular vision? We are seeing both eyes simultaneously and receiving the image as a single. So, it is both eye used simultaneously to see a particular object and perceived as a single object. I told in the beginning, we see with both the eyes, the visual axes are aligned to each other. So, we see object, image falls on both eyes, since they are falling on the fovea in both eye, which are the corresponding retinal points, and therefore, we see single image. That is the binocular single vision, simple. Okay. And I also told you, the fovea is the best example of corresponding retinal points, and there are multiple points in the retina. If the image falls on those 2 points simultaneously, then we can perceive it as single. For example, I am looking at this object, but I can see other things on my surrounding also as single. Okay, because the image of those objects falling on the corresponding points on the retina, and therefore, they are perceived as single. And this develops during the first 6 months of life. Okay, so, child does not have binocular vision during 3 or 4 months, but start developing by 6 months. Child has a good binocular vision. He has eyes are aligned. You can see, otherwise at 1 or 2 months you will find the eyes are not very well aligned in a child. Okay, the eye moves in different directions. But as the child grows, the binocular vision develops, the visual axis gets aligned, and child develops a binocular vision where the child will move simultaneously in both the eyes together and will have a orthophoria. Now, there are various grades of binocular vision. Okay, there are various grades of binocular vision. These are simultaneous perception, macular perception, means we simultaneously receive the image of the eye on the fovea, simultaneously perception. This first grade means we see the image of the object falls on the fovea in both eyes, simultaneously we see a particular object, the image falls on the fovea in the 2 eyes. This is simultaneous macular perception. This is in binocular vision, first grade. Second is we fuse these 2 images. Okay, the brain is going to fuse if they are coming from the same point, corresponding points. Then it has the same quality, same size, same shape, then brain is going to fuse it to make it a single. That is the second grade of binocular vision. And third is the stereopsis, means the perception of depth of the object. Okay, we can see the depth of any object also. Okay, so these are 3 grades of binocular vision: the simultaneous perception, simultaneous macular perception, fusion, and stereopsis. Now, how do you test all these 3 grades? Whether the child has all these 3 grades are there, fusion is there or not, or stereopsis is present, it is not present. So, there are various instruments to measure these different grades of binocular vision. So, first is the simultaneous perception. So, how do you test it? So, this instrument called synaptophore. Okay, we have this instrument in our department also, you can come and have a look. This is the synaptophore, which has 2 observation tubes. okay, and these tubes can be moved with the help of a handle, and the child has to look through this eyepiece, okay. And there are slides, set of slides are there for simultaneous perception, like a lion in a cage or a bird in a cage. So these slide has to be put here, there is a slot here where the slide has to be placed. So we place on one side the cage, other side the lion, and the child is asked with this handle to put the lion inside the cage. Means at that point the image is falling on the fovea, okay. So this child has to move the arm of this synaptophore to put the lion inside the cage. So and when we see the pupillary reflex, it will be in the center of the pupil if the child is orthophoric, okay. So when this slides are stimulating the fovea of the two eyes, they are dissimilar images, but the child is able to superimpose these two. Not able to fuse because they are dissimilar images, but will be able to put the lion inside the cage. So if this is possible, we label as the grade 1 of the binocular vision is present. Okay. So this is one instrument called synaptophore, in which there are different set of slides are there to test this first grade of binocular vision, in which you place these slides in the slots present here, and we ask the child will look through these eyepieces and will put the lion in. These are the various sets of slides are there to put the lion inside the cage. If able to put, then there is a simultaneous macular perception is there, means image is falling on the macula in the two eyes. Okay. If not able to do, means patient has a squint. In one eye it is not falling on the macula and one eye it is falling on the macula, then it will not be possible to put it inside the cage. Grade 2 is fusion, fusing two images together. Okay. So there is again another set of slide in the synaptophore, in which there is a rabbit with a tail but without bunch of flowers, and there is a rabbit with bunch of flower without tail. So again the child is asked to fuse these two images, and we ask what the child is able to see. If the fusion is there, then child will see a single rabbit with a tail and with a bunch of flowers. Okay. If not able to see, it means patient not able to fuse these two images. There is an issue with the fusion of the two images. Okay. So there are different sets of slides are there to test for the fusion. So two dissimilar but incomplete images are there in the two slides. So child has to fuse and make this image complete and tell us what is able to see. Is able to fuse this to incomplete images and see a complete image, it means the second grade of binocular vision is present in the child, otherwise fusion is absent. Again, if the image is not falling on the corresponding point, child are able to fuse these two images. Okay. So it means patient has a squint, okay, does not have a binocular vision, has a uniocular squint, or has uniocular vision, does not have a binocular vision because of some or the other reason. Okay. Does not have binocular vision, second grade. Third is stereopsis. There are different set of slides to test stereopsis, which will test the three-dimensional image. So here ability to perceive the depth by superimposing two pictures of the same object taken from different angles, and when we fuse we see the third dimension different or the depth also. Okay. And this is the simple test in the synaptophore to test for stereopsis. So in synaptophore is the instrument where we test binocular vision, different sets of slides are there to test all the three grades: simultaneous macular perception, fusion and stereopsis, right. There are other instruments also, but this is the simplest way to test for the binocular vision. Then if patient does not have binocular vision, what are the other anomalies of binocular vision? Okay. Patient does not have binocular vision, not able to see both eyes simultaneously, image not falling on the fovea and two eyes. So what are the conditions which can happen? Like patient may have diplopia, I told you double vision. Like can you give any example? Patient has recent onset diplopia, comes with diplopia suddenly. Any condition which suddenly adult patient comes with, I am seeing double, he comes like this, closing one eye, very intractable diplopia, cannot walk. You know, diabetes, mononeuropathy, patient can have LR palsy, okay, of sudden onset. Okay. So diabetic patients have mononeuropathy, so sixth nerve palsy is very common. Okay. So they will come with severe diplopia because they have a mononeuropathy, the lateral rectus is affected, and they have a paresis of the lateral rectus muscle. So suddenly they will start seeing double because lateral palsy. What is the position of the eye? It will be isodeviated, right. So patient again will have diplopia because now patient does not have binocular vision because one eye is now isodeviated, image not falling on the fovea. So there are two images seen of every object. Patient have a severe diplopia. Okay. So that is one of the anomaly of the binocular vision. Okay. So what is happening here? This muscle is paretic, the right lateral rectus muscle. Okay. There is a paralysis of the lateral rectus because of any reason. So what is happening? This eye is deviated medially, isodeviation. Okay. Because medial rectus is overacting. Okay. So because according to Haring's law, okay, according to Haring's law, equal innervation is flowing to this muscle, and therefore this muscle is overacting, and therefore there is a medial deviation, EZO deviation of this side. So now because this is the fovea, image is not falling on the fovea, it is falling on some extrafoveal point. Okay, because not falling the fovea, not falling on the corresponding points, the brain is not going to fuse these two images. So patient will have a diplopia. Okay, this is exodeviation. Either the medial rectus is paretic. So what is happening? The lateral rectus is overacting. So eye is exodeviated. When the eye is exodeviated, the fovea is moved nasally. So now image is falling on some extrafoveal point temporally. It's falling temporally, so it is projected here. Okay, on the opposite side of the eye with paresis of the muscle. It's called a crossed diplopia. Okay, so when there is a exodeviation, there is a crossed diplopia because the fovea shifted nasally because exodeviation, image is falling on the temporal projected nasally like this. So it is a crossing of the original and the other image. Here what is happening in exodeviation, image is falling on the same side of the paretic eye. So it's called a uncrossed diplopia. Okay. So diplopia will be there. Now you want to find out why there is a diplopia. Look for ocular movements, ocular movements, see the binocular ocular movements. You will find that in lateral rectus palsy, the eye is patient not able to move to the, there is no abduction present. The medial rectus is overacting, so there is a exodeviation. Okay, and it is a case of sectional palsy. You take the history, patient may be uncontrolled diabetic. One of the cause. There are many other causes also, but it could be that could be the cause. They realize the importance of Haring's law and importance of knowing the what is diplopia and why there is a diplopia, because is it clear up to here? Okay, one of the anomaly of binocular vision is diplopia. I will tell you other anomalies also, but one is diplopia. Patient does not have binocular single vision because the image is not falling in the fovea and the two eyes at the same point. So patient has a double vision. So either patient will keep the patch the eye immediately because patient cannot walk. So common cause could be diabetes. I will take other anomalies in the next lecture. Okay, so any doubts? यहाँ से शुरू करो, जो प्रेजेंट है उनका नंबर लिखो. class I am to ask you questions of this class. Okay? So come with that. First revise and then I will give you. Present लिखो first, date लिखो, time लिखो. इसका फोटो खींच के मुझे भेजना है और यहाँ को भेजना है. ठीक है.